In this video, we're going to talk about a very controversial topic in rehab, surgery. Should you get surgery or should you not? Now, for the context of this video, we're talking about hips, specifically arthroscopic hip surgery. Typically, people who are diagnosed with cam or pincer type impingements, even labral tears or loose bodies in the hip. Those are the type of candidates we'll see getting these hip arthroscopic surgeries. We'll also talk about arthritis as well, because that subject is not as black and white either. Are these surgeons bad, evil people and they just want your business and they want to cut you open no matter what? Or can it be extremely effective for people? As a physical therapist, I'm prone to believe that conservative management is always the first step. But that being said, I do feel surgery can be the best option for some people. Now, I'm not going to throw at you a bunch of studies that you'll never read with the percentage of good versus bad outcomes, because we know pain is so much more complex, and there's always a mismatch between the percentage of good and bad outcomes on these studies and what we actually see in person, especially when it comes to return to sport if you're an athlete. But I do want to share my experience, not only working through my own hip issues conservatively, but also the many clients I've worked with, both surgical rehab and conservative management, and hopefully you can decide, if you do have hip pain, what option you're going to want to take. Let's talk about hip impingement, FAI, femoral acetabular impingement. So there's two types. We have a cam and pincer type impingement. Cam impingement, you'll see a bony overgrowth on the femoral head or neck, and that can impede motion as it's trying to move on the acetabulum. The other type is the pincer type impingement, where there's a bony overgrowth on the acetabulum, so the socket. And now this overcoverage prevents the femoral head from moving. Now you can also have a mixed type where you have a cam impingement and a pincer impingement. And now what happens when you have these different bone morphologies is, when you're moving through end range, it could over time tear the labrum. And now a lot of times people go into surgery, they get an MRI, they find these labral tears on there, and this is what these surgeons are trying to repair, because the labrum acts as a suction seal for the hip. So if you tear the labrum significantly, it'll take less force to distract the hip, leading to a little bit more instability, theoretically. Because what we see in actual studies is that you can have a pretty large labral tear, but the hip joint can still function normally. Now, the problem I see with using imaging findings to decide whether you want to get surgery is that these morphological changes happen in adolescence. And most of the time, it's adults, people in their late 20s to early 40s, that are going to see the surgeons for their hip pain. And if this bony morphology changes, labral tears, were in your hip before you had pain, then how can we say that the labrum tears and the bony morphology changes are what's causing your pain? What's interesting is about half the patients that go get imaging done on their hips with complaints of hip pain also have tendinopathies in their hip, more specifically hip flexor psoas tendinopathies and especially gluteal tendinopathies. So essentially, there's a lot of stuff in your hips. We have a lot of tendinous insertions, we have ligaments, your joint capsule, we have bursa. There's a lot going on in this hip region. So what can feel like really deep pain could be just sensitivity in some of these muscular tissues at the insertion points. And we have to realize a lot has changed in your body since your teenage years and your adult years. So you might not have even noticed the hip pain, even though all this stuff was still going on when you were a teen playing sports or early 20s. And then maybe into adulthood, you wanted to get into more activities that required more range of motion at your hips. You know, when we're athletes, cutting sport athletes, our hips don't go through a ton of range of motion, but they do deal with a ton of impact. So that's when these bones are adapting to these stressors. So the cam and pincer impingements and labral tears, these are almost normal findings we see in athletic populations. About 70% of athletes who get their hips scanned, whether they have symptoms or not, they'll probably find some type of impingement syndrome or labral tearing, and they might not even have pain, because this is just a normal response to loading. You know, your bones, they adapt to load just as your muscles do. This is called Wolff's Law. So in my instance, I always knew I was stiff growing up. I could never access a lot of deep ranges. Just genetically, I was never suited for flexibility. although my hips were never in a ton of pain when I was playing soccer. I started noticing it in college because I was getting more into weightlifting and using my hips through their full range of motion. I noticed I couldn't get into a really deep squat. I couldn't move deep laterally in a wide stance position, Cossack squats. And then once you get a scan of your hips and you see all the damage done on the scan, now you start to catastrophize in your mind. Like, oh my gosh, look at all this damage. Now, every time a little bit of flare-up happens, you think it's because of what you find on the imaging, and it causes you to think, oh, maybe I do need surgery. Meanwhile, you probably just did too much too soon, and you're flaring up some of the tendons associated with your hip. So here's one tip I'll give you. If pain has just come out of nowhere, when previously you were feeling completely pain-free, that's probably a good sign that you're overloading some of the tissues around your hip, whether it's the joint capsule, whether it's ligaments, whether it's tendons, whether it's the muscles. It's probably not the labrum tear itself, and it's probably not this bone-on-bone grindy feeling that the internet might make you think is going on with a cam or pinch or impingement, okay? So in that case, you just need to be patient. You need to back off on some of the irritating exercises and movements that you're doing, decrease that sensitivity in your hip, and then start to build more tolerance to those compressed positions over time. And we could say the exact same about any sort of pathology going on in the body. You know, we see these imaging findings elsewhere, rotator cuff tears, meniscus tears in the knee, disc pathologies in the low back. There's a lot of people with these that are completely asymptomatic. Now, if you've been dealing with bad hip pain for years and it's really affecting your quality of life, then we can probably start to associate these imaging findings with some of your pain. Because in these instances, when people think they've tried everything conservatively and it just doesn't work, surgery tends to be very appropriate for them. And a lot of times you talk to these people and they think, oh, you know, I wish I got this years ago. And that's totally fine. Just because you failed conservative management doesn't mean you actually failed. It just probably means your hip was too far gone and you needed surgery. That's totally fine. I've worked with people over the course of months and years who have continued to get worse. And they finally got either a hip replacement or an arthroscopic surgery and have had good results. But I've also worked with people who have had arthroscopic surgery and they ended up worse afterwards. Because maybe you repair the damage you find on imaging, but what if that wasn't the source of your pain in the first place? What if it was muscular? What if it was ligamentous? Then it tends to just come back once you start loading the body. But a lot of times people feel great after surgery because it forces you to take a break. There's a lot of people who don't want to give up the activities that were causing the pain in the first place. Now, when I say give it up, I just mean back off on it for a certain period of time. Switch your focus. You know, get fit in other ways that aren't causing you to flare up your hips. They don't want to back off on these activities, so they look at surgery as a quick fix option. Now, what happens when you get an arthroscopic surgery is there's this progressive period of non-weight bearing, getting back to, you know, full activity around 3-4 months. And during those periods of non-weight bearing and partial weight bearing, you can't do much. You're really babying the rehab. Good labral tear rehab requires you to baby it around that 3 to 4 week mark, because a lot of times when you get these arthroscopic surgeries, hip tendinopathies are very prevalent if you start to push things too early. So another issue is maybe the labrum tear and the impingement syndrome was your source of pain, and it was constantly impinging on the joint capsule and flaring up the joint capsule, and then once you repair that, you no longer have those issues. But then it kind of opens you up for other forms of pain. Maybe you end up with SI joint pain, maybe you end up with knee pain because your loading patterns are different. They have to get deep into that joint to access the hip capsule to repair all those structures. And that means they're cutting through gluteal tissue. That means they're cutting through some of your hip stabilizers, and those tissues never end up being the same. So it all depends on what you're trying to get back to. Are you trying to get back to high-level athletics? Are you just trying to be functional in your day-to-day activity? All of these questions play a role in your decision-making. You have to understand nothing is black and white. So what you find on imaging, it's real. So I'm not saying that just because there's people who are asymptomatic with cam impingements, pincer impingements, labral tears, arthritis, doesn't mean that stuff isn't there. What that means is that you just have to be a little bit more careful with your exercise selection. So for myself, you've seen me sitting in a squat. You know, my feet are turned out. I have a relatively wide stance. I was never able to do this before, but like the activities I like to do, I like to squat, I like to train gymnastics, I like to train the splits. It just requires me to be a bit smarter about my execution and my stance. So I'm probably never going to be able to squat comfortably with, you know, completely foot forward position. You know, my hips are probably never going to fully flex above 100 degrees, 110 degrees because of my limitations in my morphology. And that's okay. I might just have to abduct the hip a little bit more to squat. I could still do everything I want to do. And the more I try to look like people without these bony morphology changes, the more I flare up my hips. The more I try to walk with my feet completely straight. You know, of course, I've come a long way, and there's a lot of muscular limitations that could, you know, cause you to walk duck-footed or cause you to excessively squat with a wide foot turned out stance. There's a lot you can get done. My rule with this is as long as you feel a stretch, you're good to go. So like improving my hip internal rotation, I used to have 0 degrees on this hip, but if I sat in a 90-90 or done any other internal rotation stretch, I still feel a good stretch in here when I do this. I might not ever get to the full textbook 45 degrees of hip internal rotation, but I've certainly come a long way, and even cold, I have some internal rotation to play with here now. And that's transferred significantly into how my hips feel when I train for the splits or when I train for my squats. So I could do all of that stuff relatively pain-free, but I'm human. Like, I get flare-ups. My hips aren't completely pain-free all the time. And I want people to understand that it's totally normal to have these flare-ups. But now I know, once my hips flare up, I've been around the block so many times that I know it's not permanent. I know if I back off on my activities and then slowly ramp back up, my hips will get right back to being pain-free. I like to treat FAI type of symptoms like tendinopathies because often that is what is the source of the pain. The tendons being irritated by the constant compression. So I teach my clients how to get comfortable in these compressed positions, how to build tolerance to compressed positions, and that comes with building strength at end range. And I think that's an extremely overlooked aspect of rehab that a lot of practitioners aren't taking their clients through. And this is what helped me significantly. And then, of course, training some of the muscles around the hips that are very commonly overlooked in strength and conditioning programs, like specific work for the adductors, specific work for the hamstrings, specific work for the glute medius. Traditional strength programs are all sagittal plane, right? Up and down. We don't train in different planes of motion. And that can cause the hips to be overworked and overdeveloped in certain areas and underdeveloped in other areas. And that can lead to abnormal centration of the hip in the socket. When it comes to arthritis, we see a lot of the same things: bone spurring, cartilage loss. We even see people who are completely bone on bone, but they have no pain. Here's a funny story. My dad developed some neck pain, really stiff guy, and it was starting to get worse. You know when you tweak your neck from sleeping or something, it just stays there for a long time, maybe 4 to 6 weeks. So he went and got a scan. It showed very little joint space, and they wanted to send him to an orthopedic surgeon. Meanwhile, he just had a tweak in his neck, and that stuff just takes a long time to heal. And the surgeons were saying they wanted to do a fusion surgery because there was such little space between the discs. The discs were completely degenerated. And I told him to tell those surgeons to fuck off because he just had some inflammation in his neck. Like, this degeneration in his neck was happening for years before there was any pain there. And he was always very stiff and limited in range of motion, but never any sharp pain, right? So just because there's severe degeneration doesn't always mean it's going to correlate with pain findings. So you have to understand that. Now, what I do tend to find is when there's no more cartilage left in your joints, that's probably time for a hip replacement or a joint replacement because there's no more shock absorption there. That's the point where the joints are just kind of too far gone. You've pushed them past the limit of any sort of recovery. This is the main thing. If it's really impacting your quality of life, no matter what age you're at, then maybe it is time for that hip replacement, and that's totally fine. So if you didn't have good results with conservative management and strengthening and stability-based exercises, it doesn't mean you're a failure. It just means you pushed your body past the point to where it can recuperate and regenerate. If you have zero cartilage left and it's really impacting your quality of life, and you can't walk, you can't sit for prolonged periods of time, and you can't sleep, it might be time for that joint replacement. And just because you get a joint replacement doesn't mean you can't do a lot of the things you love. Now, just so you know, it probably doesn't mean you're going to be training like you did back in your 20s or 30s. A lot of times people think they're going to get these joint replacements and they're going to be invincible. That doesn't work like that. There's still limitations to them, but you could be completely functional. You know, you could play tennis, you can go on hikes, you can strength train very safely. And also a note about strength training in general, when it comes to labral tears and impingements, there's probably a 2% load on the labrum when doing something like a back squat. So just know that heavy, slow resistance training is so safe for your body, and a lot of these exercises we do in the gym aren't going to really be taxing your labrum. So it's the exercises that are very high impact, like sprinting, cutting, absorbing jumps. Those are the activities that are going to stress the labrum a little bit more. So heavy, slow resistance training and mobility work is so healthy for your connective tissue to build robust connective tissue, muscle, and tendon structures to protect the labrum and make sure that you're not overly stressing your connective tissue when you're training. So this is why conservative rehab works so well when you do have FAI. 80% of the population can go without an arthroscopic surgery. I've worked with so many people with labrum tears and FAI that go through the same journey as I have, and they don't ever need surgery. So I hope this video offered a bit more insight into why surgery may be a good option and why it may not. So what do you guys think? What is your experience with hip pain? Let me know in the comments. Let's have a conversation about it.